Bismillah ar-Rahman ar-Rahim. Antidepressants Part 2. Tricyclic antidepressants. The tricyclic antidepressant will block the norepinephrine and serotonin reuptake into the presynaptic neuron. This is a new group as antidepressant drug, and thus, if it is discovered today, it might have been referred to as serotonin norepinephrine reuptake inhibitors, except the difference for their adverse effect relative to this new class of antidepressant. The tricyclic antidepressant include the tertiary amines and the secondary amines. The tertiary amines include emperamine, which is the prototype, amitriptyline, clomipramine, doxapine, and trimipramine, while the secondary amines include desperamine and nortriptyline, which is the N-type enantiomer of demethylated metabolite of emperamine and amitriptyline respectively, and protriptyline. Maprotyline and amoxapine are relatively tetracyclic antidepressant agent and are commonly included in the general class of tricyclic antidepressant because they have the same use. Patients who do not respond to one tricyclic antidepressant may benefit from another different drug in this group. Mechanism of action. Number 1. Inhibition of the neurotransmitter reuptake. Tricyclic antidepressant and amoxapine are potent inhibitors of the neuron reuptake of norepinephrine and serotonin, as we said, into the presynaptic nerve terminal. This part of the presynaptic serotonin nerve terminal and this part of a presynaptic noradrenergic nerve terminal. Maprotyline and desperamine are relatively selective inhibitor of norepinephrine reuptake. We see here that the maprotyline and desperamine acting only on the left side, acting only on the noradrenergic neuron reuptake. Number 2, mechanism of action, blocking of the receptors. Tricyclic antidepressant will also block serotonergic, alpha-adrenergic, histaminic, muscarinic receptors. It is not known if any of these actions will produce the therapeutic benefit of the tricyclic antidepressant. However, the actions at these receptors are likely responsible for many of their adverse effects. Actions. The tricyclic antidepressant will elevate mood, improve mental alertness, increase physical activity of the patient, and reduce the morbid preoccupation in 50 to 70% of the individual with major depression. It is a good percent. The onset of the mood elevation is slow and requires 2 weeks or longer. Patient response can be used to adjust dose. After therapeutic response, the dosage can be gradually reduced to improve tolerability unless relapse is occurred. Physical and psychological dependence has been rarely reported. This necessitates slow withdrawal to minimize the discontinuation syndrome and cholinergic rebound effect. So they need slow withdrawal. They need tapering in order to decrease the cholinergic rebound effect and the discontinuation syndrome. Therapeutic uses. The tricyclic antidepressants are effective in treating moderate to severe depression, and some patients with a panic disorder also respond to this group of drug. Emperamine has been used to control bedwetting in children older than 6 years. However, it has largely been replaced by desmopressin. The tricyclic antidepressant, particularly amitriptyline, have been used to help prevent migraine attack and treat chronic pain syndrome, for example, neuropathic pain, in a number of conditions for which the cause of pain is unclear. Low doses of tricyclic antidepressant, especially doxapine, can be used to treat insomnia. Pharmacokinetics. Tricyclic antidepressants are well absorbed upon oral administration. Because of their lipophilic nature, they are widely distributed and readily penetrate the CNS. As a result of their variable first-pass metabolism in the liver, tricyclic antidepressants have low and inconsistent bioavailability. These drugs are metabolized by the hepatic microsomal system, thus may be sensitive to agents that induce or inhibit the cytochrome P450 enzyme. Tricyclic antidepressants are excreted as inactive metabolite via the kidney. Adverse effect. The blockade of muscarinic receptor lead to blurred vision, xerostomia, which means dry mouth, urinary retention, sinus tachycardia, constipation, and aggravation of angle closure, glaucoma. The tricyclic antidepressant also block alpha-adrenergic receptors, causing orthostatic hypotension, dizziness, and reflex tachycardia. Sedation and weight gain is commonly adverse effect of the tricyclic antidepressant. Sexual dysfunction occurs in minority of patients, and the incidence is lower than that associated with selective serotonin reuptake inhibitors. Tricyclic antidepressant, like all antidepressants, should be used with caution in patients with a bipolar disorder, even during their depressed state. If the patient is also in the depressed state, it should be used with caution in those patients that suffer bipolar disorder. Why? Because antidepressant may cause a switch to manic behavior. The tricyclic antidepressant have a narrow therapeutic index. For example, 5 to 6-fold of the maximum daily dose of emperamine can be lethal. It is very dangerous. Depressed patients who are suicidal should be given only limited quantities of this drug and can be monitored closely. The tricyclic antidepressant may exacerbate certain medical conditions such as benign prostate hyperplasia, epilepsy, and pre-existing arrhythmia. Monoamino oxidase inhibitors. Those are mitochondrial enzymes found in nerve and other tissues such as the gut and liver. Those enzymes are, as I said, a mitochondrial enzyme. In the neuron, the MAO enzyme function as a safety valve to oxidatively deaminate and inactivate any excess of the neurotransmitter like norepinephrine, dopamine, and serotonin that may leak out of the synaptic vesicles when the neuron is at rest. So it is act as a safety valve. The MAO inhibitor drug may irreversibly or reversibly inactivate the enzyme, which is the MAO, permitting the neurotransmitter to escape degradation and therefore to accumulate within the presynaptic neuron and leak into the synaptic space. So if we have a neuron and we have a neurotransmitter, the action of the MAO enzyme to target any escaped neurotransmitter like the serotonin transmitter or the norepinephrine transmitter and degrade them. So when we inhibit this enzyme by giving MAO inhibitor drug, it will stopping the action of the enzyme to degrade those neurotransmitters. So more neurotransmitter will escape and go to the end of the synapse and lead to more concentration of the neurotransmitter to act with the releasing and attacking the postsynaptic receptor. So those enzymes are present mainly in the presynaptic neuron. The 4 MAO inhibitors currently available for the treatment of depression will include phenylazine, tranylcypromine, isocarboxylide, and selegiline. You have to note that selegiline is also used for the treatment of Parkinson's disease. It is the only antidepressant available in a transdermal delivery system. The mechanism of action. As we said, most of MAO inhibitors, such as phenylazine, form a stable complex with the enzyme, causing irreversible inactivation of the enzyme. This results in increased store of norepinephrine, serotonin, and dopamine within the neuron, and subsequent diffusion of the excess neurotransmitter into the synaptic space. These drugs inhibit not only the MAO in the brain but also MAO in the liver and gut that catalyze the oxidative deamination of drugs and potentially toxic substances such as tyramine, which is found in certain food. The MAO inhibitors therefore show a high incidence of drug-drug and drug-food interactions due to this action. Selegiline, administered as a transdermal patch, may produce less inhibition of the gut and hepatic MAO at low doses because it avoids the first pass metabolism. Therapeutic uses. The MAO inhibitors are indicated for depressed patients who are unresponsive or allergic to tricyclic antidepressant and selective serotonin reuptake inhibitors, or who experience strong anxiety. So either it is used for the unresponse or allergic to the famous group, which is tricyclic antidepressant and the selective serotonin reuptake inhibitor, or who experience strong anxiety, not mild to moderate, strong anxiety. A special subcategory of depression, which is called atypical depression, may respond specifically to MAO inhibitors because of their risk for drug-drug and drug-food interactions. The MAO inhibitors are considered last line. It is considered as the last line agent in many treatment settings. Pharmacokinetics. These drugs are well absorbed after oral administration. Enzyme regeneration when irreversibly inactivated varies, but it is usually occurs several weeks after termination of the drug. Thus, when switching antidepressant agent, a minimum of 2 weeks of delay must be allowed after the termination of MAO inhibitor therapy and the initiation of another antidepressant from any other class. So it need 2 weeks in order to clear from the body and to start a new drug. MAO inhibitors are hepatically metabolized and excreted rapidly in the urine. Adverse effect. Severe and often unpredictable side effect due to the drug food and drug interactions limit the widespread of this group of drug, which is MAO inhibitors. For example, we have the tyramine, which is contained in foods such as the aged cheeses and meat, chicken liver, and pickled or smoked fish, is normally inactivated by MAO in the gut. The individual who receiving this type of group of drug, which is MAO inhibitor, are unable to degrade the tyramine obtained from the diet. So high concentration of tyramine is present. Tyramine will causes the release of large amount of stored catecholamines from the nerve terminal. This will resulting in a hypertensive crisis with signs and symptoms of dangerous signs and symptoms like occipital headache, stiff neck and tachycardia, nausea, hypertension, cardiac arrhythmia, seizure, and possibly stroke. Phenytolamine and prazosin are helpful in the management of tyramine-induced hypertension. Other possible side effects of treatment with MAO inhibitors include drowsiness, orthostatic hypotension, blurred vision, dry mouth, and constipation. Due to the risk of serotonin syndrome, the use of MAO inhibitors with other antidepressants is contraindicated. Both selective serotonin reuptake inhibitors and MAO inhibitors require a washout period of at least 2 weeks before the other type is administered, with the exception of fluoxetine, which should be discontinued at least 6 weeks before the MAO inhibitors is initiated. This is an exception for the fluoxetine. In addition to that, the MAO inhibitors used with caution with other drugs. The last topic in this lecture, treatment of mania and bipolar disorder. Bipolar disorder is a mental disorder that causes period of depression and period of abnormally elevated mood. The treatment of bipolar disorder has increased in recent years due to increase the recognition of the disorder and also an increase in the number of the available medication for the treatment of mania. At past student, those disease was unknown and there is no treatment for those disease like bipolar disorder. It is considered as a new disease. So there is no group to be treated before, but when they are discovered those drugs, it was easier to be treated with it. You have to notice that those group of people, whether they are suffering from mania, whether they are suffering from depression or bipolar disorder or any other psychological disease, you have to pay attention for those group of patients, and you have to try to enroll them in the society. You have to try to make them more happy and more adherence with the drug they taking for, with the psychiatrist they visited. You have to deal with those group of patients carefully, and you have to understand their disease because it is a very complicated disease, and the rate of treatment is very low, and if you control their behavior, this will be sufficient. So we came for the treatment of the bipolar disease, and we see here we have lithium. Lithium salt are used acutely and prophylactically for the management of bipolar patient. Lithium is effective in treating 60 to 80 of the patient exhibiting mania and hypomania. The mode of the action is unknown. The therapeutic index of lithium is extremely low, and lithium salt can be toxic. Common adverse effects may include headache, dry mouth, polydipsia, polyuria, polyphagia, gastrointestinal distress. Give lithium with food to avoid this distress. Fine hand tremor, dizziness, fatigue, dermatologic reactions, and sedation. Adverse effect due to higher plasma level may indicate toxicity and include ataxia, slurred speech, coerced treatment, confusion, and convulsion. Unlike other mood stabilizers, lithium is renally eliminated. Other drugs, several anti-epileptic drugs including carbamazepine, valproic acid, and lamotrigine have been approved as a mood stabilizers for the bipolar disorder. Quetiapine, lorazepam, and the combination of the olanzapine and fluoxetine have been approved for the bipolar depression. You have a homework, student, but it is done for you only. Do not send them for me. Number 1, what is the differences between the secondary and tertiary amines? Number 2, homework, what are the differences between MAO-A and MAO-B enzyme? If you have any question, you can write them in the Google Classroom to discuss them. Thank you.